Well, good morning. Sorry we're running a little late. It took Facebook a while to accept that we wanted to be with you. Apparently, it wasn't sure whether we should all get together this morning. I don't. Maybe it knows I'm going to talk about stuff it doesn't want people to know about. Oh, who knows? Probably some tech glitch somewhere. Anyway, not being too paranoid. All right, Matthew. So far this week, we've been spending some time talking about what happens when you get your diagnosis, or maybe at least your syndrome identified. And what's the most common thing that your medical provider is likely to do after that, immediately following that? And we've done a couple of pieces on that. So today, I thought we'd focus on, so what exactly do medical providers, what are the most common practices of a medical provider in prescribing something or telling you should do something when you first get your diagnosis? Okay. So what I'm going to do is share with you what the top ones are. Okay. These are the most common things that a medical provider has people do when they are developing, when they've been identified as having a dementia. Okay, here they are. These are the most common. Okay, Matthew, can you see my slide? I just want to make sure. Okay, so here's the most common one. Okay, this is number one. Here's some meds that are going to help you with your symptom management. But we talked the other day, maybe yesterday, about sometimes how they say that is not accurate. It's not, here's some meds that you could try to help with some symptoms if these are the symptoms you're having. Instead, it's said in a different way, or it's perceived in a different way. Now, it could be either, it could be both. But that's the most common thing, that if you ask a medical provider, what do? They try people out on the acetylcholinesterase inhibitors. And the other thing they might try is a glutamate moderator. In other words, they try meds, even though those meds are like 1/3, people might get a benefit if you're picking the right med for the symptoms. 1/3, it's not doing anything. And 1/3, it's actually causing some other problems for somebody. So, but going through what you normally go through isn't as frequently as carefully done as it might be for other health conditions, because you're just throwing something at it because you don't know what else to do frequently. The second most common prescription, and this is a very common one, is they might get some more meds to help with some other conditions. So they might be doing some adjustments to other health conditions, medication-wise. So they're adding some new meds or some new ways of trying to treat other health conditions, even though what I just gave you was an identification of a condition that makes it hard to do different new things well on your own. And I just gave you devastating news that what you have is going to be changing your brain and your life from now on. And so here's what we're going to do with your other health conditions, which to me is like, okay, so now we're going to work on this? Or, you're still thinking that my other health conditions are going to be easily managed, even though you just gave me this brand new piece of information that my brain is dying. And that you don't have really a way to fix it, except maybe you said something about these meds slowing my condition down, which, everybody jumped on board with, even though that's not exactly accurate. And now we're going to work on the other health conditions I have. It seems like we're avoiding the elephant in the room to me, but these are two very most common things. And there's the third thing. Recommendation that you better get your affairs in order. You need to select durable healthcare power of attorney. You need to figure out your financial stuff, because at some point, you're going to lose the ability to do all that. So you need to go do that. So those are the top 3 things that happen. And it's like, but wait, it seems like there should be some other stuff. And this go get your affairs in order is just like go home and get ready to die. I mean, that's how people living with dementia frequently interpret it. It's like, okay, so there's nothing I can do for you. So you just need to get it together and just go hang out. And so this frequently results in an extreme depression. Extreme. People call it going into a cave. People call it shutting down. Or people go looking, this is ridiculous. I don't think that's what it is. you go seeking something else. Or you go get your affairs in order and give up. None of those things are exactly what we're looking for, if you want to be honest. So here are the other two things they do. I mean, and I say I'm talking about medical providers that are not into living well with dementia. So it's not all medical providers, but unfortunately, these are the most common things people do. Recommendation, you need to stop driving. But it's not a recommendation, it's you need to stop driving. Or, oh, I think you're still fine driving right now. But it's either you need to stop driving or, yeah, no, he's good to drive right now. Depending on how soon in your dementia and how you present yourself in your evaluation. And then the next one is you need to stop working. Or I think he can keep doing what he's doing for a while. So, Matthew, would you call that a reasoned, sort of thorough evaluation of abilities, or would you call that an opinion piece?
Yeah, Teepa, I'm starting to pick up on more of that opinion side in that moment, and again, this is only after how long of being with the person that there's.
Yeah. I mean, somewhere between, often between 30 minutes, 15 minutes of active time, reviewing some information, looking at some test results, quote unquote, which is frequently maybe what do people most frequently do? I think they're doing MRI. No, they're not doing MRIs. Well, sometimes they are, not very often. They're doing CAT scans, or they might do something to sort of check and see if there are any masses. They'll do some blood work. I mean, again, it's sort of not necessarily done with a lot of very careful thought. But sometimes even with careful stuff, still, it's this picture of somebody in a moment, not a video of how they're living their life. And this careful evaluation of stuff. I mean, you just gave somebody a piece of information that it would be like, okay, you've got pancreatic cancer. We're going to try you on a couple meds. And on the meantime, we really need you to be more careful about your glucose. So what we're going to have you do is really, I'm going to put you on some insulin, and it's going to be a sliding scale, and you're going to have to, and you probably should go ahead and get your affairs in order. And because you're so weak, I'm going to have you stop driving and not work anymore. Because this pancreatic thing, oof, boy. All right. I'll see you in a couple, I'll see you in about, let's say 6 to 8 weeks, see how things are going for you. But we wouldn't accept that. Wait, what? Wait a minute. What did you say? But often, it's sort of like I've done the thing I know how to do. So, and I'm not being mean. I'm just saying that's the most common pattern that people are talking about. Oh, yeah. And then we have this one more. So you should start eating better and exercise more. But you just told me no matter what I do, I've got dementia and it doesn't really matter. Is that right? I mean, so this is sort of the laundry list of what people get. So what do I think would be better? That's really what I want to focus a little bit on. What do I think would be better? What would I recommend? Well, number one, first thing I think we need is a return visit in 1 week to process everything you just heard and what was said. We aren't going to try, or maybe in a few days, depending on the person. We need a return visit. And we need somebody to come back and let's make sure that what we thought we said, what people thought they heard, what we got to decision-wise, what we determined, whatever we did, that there is time to come back and let's see where things are and let's talk some more. Because I think from what you've described, I think from what, that we're hearing about from those around you and what I saw and where we are, I'm feeling like this is something we're going to have to dig into a little bit more. It sounds like you have some cognitive changes. We've really looked at other possibilities. I think what we're looking at is something that is going to impact your life. And we need to start thinking about that. So I want you to take a week, see what you think about this idea, how you feel about that. And we're going to come back together and we're going to have a conversation then about next steps. Because there's a lot to be thought about here and figured out. Now, how does that sound different than what was said the first time, Matthew? Because here's our first list. And here's my recommendation.
Yeah. So actually giving somebody time to process just that initial piece. And I know we talked about that on the last episode, this idea of when you give somebody news like this, what's the likelihood of anything past that point being able to be recalled by that person after that, or processed, or so this idea of go take a week, wrap your head around it, think about that, and before we start doing anything else.
Yeah.
Like giving,
what is that week going to give me too when the person comes back and they say, so are we going to do an evaluation of me? If that's what the person says, what does that tell me about what they held on to? This is also my opportunity as a health provider to see what was retained over that week. What kind of questions does the person have? What kind of questions do they have a support? Is the support with them a second time? I mean, it gives me a lot more things. And when I said it, I didn't say, oh, you have dementia, and, I don't really know what to do. It was like, it does look like your cognitive changes are going to be progressive. We're going to have to look at something that's more intense. But I don't think it should have sounded like this is the end of the world and everything's downhill from now. There are going to be changes. We're going to have to make changes for sure. But I'm not sure exactly what changes we're going to have to make until we get back together. Now, here's the other thing I think should happen at that point. There should be a pharmacy consult to evaluate everything the person is on. Because I want somebody who's really good at looking at interactions, pharmacy interactions, and all the different meds somebody might be on because they see different doctors and over-the-counter stuff. I want to really have somebody look carefully at all that. We talked about the beer scale and being thoughtful about that, but I really want somebody besides me. I want somebody additional to me who knows what they're doing to really look at everything that person is currently on. And then be thinking about the kind of dementia they might be showing us symptoms of, given everything I've gotten so far. So we go, okay, so, all right, now that we got that. And if I was counting on them being able to self-report all the meds, and we know that we're having issues in certain areas, that may not be helpful. And then the other one is, this is my other, so depending on the medical provider's availability, their resources. The other thing I think is essential is referral to a support, education, and connecting kind of organization who has somebody who's knowledgeable and skillful. So this person or people or organization has to be skillful and knowledgeable about this thing called the umbrella called dementia. So if it's not your bailiwick, if it's not your skill set, you need to get somebody to people who are. And this includes peer support groups. It includes educational information. It includes connections that might be helpful to them and their support. So those are my top three that I think should be on the prescription pad. For when we think what we're looking at, we're pretty sure we're sure it's some kind of dementia, unless something really weird is going on, and we might even know what type. But that's sort of, I think, the essentials. So, Matthew, thoughts?
Yeah, definitely agree, Teepa. The idea of how this could be another way of helping folks after something like this to really give them the most we can. Because knowing that in some places there might be a limit on how many folks are out there that can be able to support and educate or things like that at certain points, but still this idea of how this could benefit that person after a diagnosis, like one of dementia.
Yeah.
That support that could be there for that person, because that's one of the biggest things that we hear from a lot of folks, Teepa, I know on our comments, is people saying, yeah, we got the diagnosis and we didn't know what to do. We didn't know where to go. We were handed a script for pills to help, and then that was it.
That was it. So now I say all this, but here's the tricky part. 70% of the time, we're talking about people who are in the middle. They've been in the condition for a while, and they're dealing with it in the mid state of this condition, whatever it is, whichever dementia they have or dementias. But for some people, it really is very early. But the reason people go to see a medical provider is usually a crisis, a problem with another health condition, all those kinds of things, or, thinking it is dementia and wanting to be in a confirmation, believing it couldn't be dementia and looking for another out. So knowing that people come into this differently, I would still be thoughtful about making sure I know why people came. Like, was it a behavioral problem? Because this is not going to suit people unless I frame it in a way that's helpful to them. So I know you're worried about him not sleeping. The first thing I want us to do, now that I've had a chance to look at everything, I want to get all the meds evaluated to make sure we're not missing something in the med category. I also want to see you back in a week. Now, do you think you can survive that long with what's going on? Okay. If not, I want you to start learning a little bit more about what you might be dealing with. So I'm going to, refer you over to X so that you can get a little more awareness of this thing that I think you might be living with. And when we come back together, then we can figure out the situation rather than just the behavior. Because we need to think about this as a situation now, not just a behavior on one person's part. And I know you want a quick fix. Anything I do quick could actually make things worse. Because unfortunately, this is not a quick fix condition. We're going to have to be thoughtful and careful, or we'll modify one thing and then it's like sticking your finger in the dam. So we need to be thoughtful about this. And I hate that because I know you want something really quick. How is that different, Matthew?
Yeah. The power of that bringing to the surface, because that's what I think a lot of folks are looking for. This idea, it's just a pill, right? We just need to add a pill, or she just needs to take a pill, or he just needs to take a pill. Mm-hmm. But bringing that piece up, unfortunately, this is not something where if we try to do something quick to fix it, that it could be a benefit. In fact, in that key piece you said there, Teepa, it could actually make things worse. If we just jump in and start doing this stuff. And I think, unfortunately, for a lot of folks, they don't see that side of, that this could actually, if I just get a pill for this, or if I want something right now and we don't take the time to look into it, we could actually make this worse. So, and
reminding myself, why is it that they came to me? Why did they come to me? Because I need to keep that in mind as I'm trying to be helpful. Because if I don't address the reason somebody came to me. Now, what was totally missing from that? Get your affairs in order. Why? Because that's not where we start. I mean, eventually, yes, that is a conversation to be had. But my analogy of playing baseball, it's like you want to hit a home run, except what's their home run when you're telling people to get their affairs in order? I mean, that's a conversation, advanced directives. That's something to say as we move forward when we've established a solid relationship. Not something I should be saying like from the very beginning of identifying you have a health condition that's going to change your life. It already has probably. That's just really different. And it's seeing dementia as a ever-changing disability that's going to involve lots of changes and people and situations, but it's not seeing it as a death sentence immediately. And, we've got to move away from that. Oh, her brain is dying. Oh my God. Yeah, it's true. It's all going to happen. But, that's true if you have diabetes. I mean, depending on a lot of factors, you got diabetes, your systems are not working. But there's a big difference between managing your life well so that you're not very likely to have a leg amputated or another leg amputated, or lose sensation in your fingertips. That's a real difference, or go blind, diabetic retinopathy. There are things you can choose to do that will change the course of your journey. And that's true about dementia too. Whether you're the person who's deliberately living, who has it inside themselves, or you're the person who's trying to support. So we're going to be doing more from those perspectives. But for right now, we're talking about these medical providers and medical professionals who are involved. So we have one more segment that we're going to focus in on this. And that is, what else do I recommend? What other sort of shifts do I think are really important? And, we'll do that on Friday, I think. Or is it Thursday, Friday?
So
now we have our Courageous Conversation launching, the second piece of it launching today. And so then the question becomes, okay, so when is that follow-up conversation we're having with Mel?
So Teepa, Friday we'll have Canel on with us to visit. So tomorrow we should be able to
finish it off for this week. Yeah. So we'll finish it off tomorrow. It's like, it's hard to keep up with which one is which, because we switch things around for our guests sometimes. And it's like, oh, which day is she doing it? She's doing it Friday. So we will see you on Thursday. All right. So Matthew, any final thoughts or comments that we have coming in?
Yeah. A lot of folks definitely commenting on, oh my gosh, this is exactly what happened, with us, is it was just, here's some meds, go get your affairs in order. There was no talk of what are some other things this person can do, or the other parts of the person's life. It was just the diagnosis and then done in a sense. So this idea of, wow, the power and the support that could come from this, how much better this could be truly for somebody in this situation, to help them see that. Because like you said, it's this idea of, okay, go get your affairs in order. Well, what does that tell me what does that tell me about the rest of my quality of life and what I should be doing from here on out, versus this idea of, hey, let's figure out what we can do to still live well and have value and purpose, and let's go from there.
What's the new normal? What's your new normal with this disabling condition you have? And it is disabling, but you still have abilities. So what's the new normal for right now? And what's it going to look like as it possibly moves forward? Yeah. Well, we all have a hand in it. So let's see where it goes. All right, everybody. So for today, take care with your care and take care of yourselves out there. I know down the road of this week, we're expecting some more weather, the kind that we don't usually get. So I've got a feeling that we'll be going, oh no, all over again. We'll see whether or not the boys make it to our house or not. All right, everybody. Take care. We'll see you tomorrow morning.
Bye.
Bye, everybody.